Thank you. Thank you. It must be a very big honor to me because we have a big guys from the USA. Thank you for coming again. So today's my topic is peripheral artery disease. Really, exercise rehabilitation may be helpful to peripheral artery disease. So usually, compared to the cardiac rehabilitation, PAD rehabilitation is called as the vascular rehabilitation also. As you know, the ACCVD is a similar disease because it can affect not only carotid, cerebrovascular, and cardiovascular system, but also in artery in the lower extremity, which typically manifested with the intermittent claudication. That is a very classic symptom of a peripheral artery disease. So, PAD can affect more than 230 million adults worldwide, quite surprisingly, and which can be diagnosed or screened by the ankle block and less than 0.9. Who is at risk of the PAD? More than 65 years old, even younger ages with diabetes, smoking must be checked for the possibility of PAD. Typically, patients present with the intermittent claudication, but sometimes they progress with the chronic limb-threatening ischemia, but majority of the patients did not have any symptoms. So even in asymptomatic symptom, we must manage the PAD patient. So the clinical situation may be changed according to the time or the situation, from the asymptomatic, chronic symptomatic, and sometimes acute limb ischemia. So, what is the major risk factor? Diabetes, smoking is the main risk factor. Also, hypertension, hyperlipidemia, and sedentary behavior also play a very big, important role in development of PAD. Other sclerosis, they reduce the blood supply, which leads to ischemia. This turn causes the damage and degeneration of the calf muscle, affecting the myofibers, mitochondria, at the cellular level. As a result, the leg muscles are unable to function properly, which causes impaired working distance. If the condition worse, can eventually lead to the complete loss of the mobility. So this figure is quite simple. At rest level, skeletal muscle received only about 15 or 20% of the cardiac output blood flow. However, during the exercise, this skeletal muscle can increase as much as the 70 or 85% of the cardiac output. Consequently, the increase in cardiac output from exercise is presumed to have the most direct and significant effect on the peripheral muscle. In particular, the biological process within the skeletal muscle that result from the working exercise are believed to have the several benefits, such as the increased nitric oxide level, improved mitopathy, enhance mitochondrial activity, promote the regeneration of the muscle cell, and the function of myofiber. Skeletal muscle contraction also is associated with the several physiological, metabolic, and mechanical mechanisms that, when repeated over several weeks and months, with the mitochondrial biogenesis, angiogenesis, and increase the functional capacity of the individual with peripheral artery disease. So, walking limitations are associated with a marked impairment in functional states and health-related quality of life. Sometimes the patient with the PAD present with the impaired working endurance, slow working velocity, gait abnormality, poorer muscle strength, and poorer balance compared to individuals without PAD. Also, another key characteristic of the PAD is the high likelihood of having the other concurrent vascular disease, known as the polyvascular, shortly PVD. Specifically, coronary artery disease is reported to occur in approximately between 25% to 70% of the patient with the PAD. The high likelihood of having the polyvascular disease, which is quite a very poor prognostic factor of the clinical situation. So, many of the recording data, we know that PAD is known to have a greater, about 4 or 5 times higher risk of the cardiovascular event. This includes not only MACE, cerebral disease, also lower limb events, so shortly male risk. So the treatment goal of the PAD can be broadly divided to two main categories. The first one is the save the limb. This is the original goal. Second is the save the limb. Then to reduce the MACE. Finally, also we have to take care of the quality of life of the PAD patient. So in JACC journal published like this wonderful table. For the save the life, smoking cessation, walking program, blood glucose, lipid level is very important. For save the limb, smoking cessation, walking, silostazole, and revascularization is very, very important. So as you see, walking exercise program can do the both of the side of the purpose. So according to 2024 PAD guideline, AHA PAD guideline, supervised exercise therapy and structured and community-based exercise program, also alternative programs such as the non-working structured exercise therapy, such as the arm ergometry, recombinant stepping, can be beneficial. This is quite a very advanced sentence from me. Also, in the symptomatic PAD patient, as you see here, structured exercise therapy must be considered as a class 1 and level of evidence A. Another Europe guideline also they stress the use of the supervised exercise therapy, and they explain the more detail how to do vascular rehabilitation, such as the duration, length, and how to deliver. Listen to the civic rehab study. They did it using the 118 patients with the individual randomization, and they reported that cardiovascular rehabilitation could increase the walking distance in patients with interclaudicant patient. How about the umbrella review? This is one of the biggest review. Synthesis of the currently available meta-analysis suggests that regular exercise may be beneficial for a broad range of the functional tasks, improve health-related quality of life in patients with PAD. Supervised aerobic exercise is the best type of exercise to improve working-related outcome and pain, but also resistant exercise also is more effective to improve the lower limb strength. According to the recent Cochrane database review, effects of the exercise therapy shows the dramatically improved the quality of life and the pain-free walking distance and maximal walking distance. Another review article also reported that supervised exercise therapy could improve maximum walking distance and pain-free walking distance. So what about the effect of the supervised exercise therapy? Compared with the unsupervised exercise therapy, supervised exercise therapy associated a moderate improvement in claudication distance 6 months and 12 months. So supervised exercise is more effective than unsupervised exercise at improving symptoms. So if possible, physician must recommend supervised exercise firstly in your PAD patient. In the last 3 decades, numerous trials seek to evaluate the role of the exercise in PAD. Their study designed were heterogeneous and also results were too diverse to interpret simply, but consistent message was that supervised exercise might be effective as revascularization alone or had an additive effect after revascularization. Collaborator is one of the very famous trials. Collaborator study was a randomized trial which evaluated supervised exercise and the only medical therapy due to the aortic peripheral artery disease. When you look at the figure, supervised exercise therapy was associated with significant improvement. In conclusion, both supervised exercise and stenting therapy has a better 18 months outcome than optimal medical therapy. Both of the two provide a comparable, durable improvement. So, not only revascularization, but also supervised exercise also may be effective in peripheral artery disease. But ERASE trial showed quite different meaning. Exercise therapy only, not equivalent to the exercise plus revascularization. So, if possible, first revascularization and adding the supervised therapy may be more beneficial. How about the different setting? Usually, very similar to cardiac rehabilitation, we must recommend center-based supervised exercise, but sometimes this is not possible. So in this situation, MS order, home-based treatment may be considered. So, beyond the hospital, such a program is not supervised exercise, or we think the alternative. So, Mosaic trial, they evaluate the home-based exercise program, and they demonstrate a significant improvement in walking distance compared to user care. But how about the home-based intervention of the wearable technology or telephone coaching? The annual randomized trial investigated such of the brand new technology and telephone coaching for the PAD patient. Unfortunately, the study found that these results do not support home-based exercise, intervention of the wearable device, and telephone counseling without periodic on-site visit to improve working performance. So, quite disappointed. How about the intensity of the home-based exercise? The right randomized trial evaluates the high-intensity home-based working versus low-intensity working versus usual care. What is the high-intensity exercise? As you see, the pace listing moderate to severe ischemic relaxation. This is very, very important, the exercise intensity. And finally, the high-intensity only exercise group worked the face showed the significant improvement, not in light intensity home-based cardiac peripheral rehabilitation program. So functional improvement in symptomatic PAD with the IC remains still challenging. Our recent novel findings may favor multidisciplinary way to maximize benefit and to minimize risk of the supervised by home-based exercise therapy or the wearable device or the MS, etc., etc. So, but this is very promising. But however, there is still a long way to go, and more evidence from numerous studies is needed. How about the practice? From the very personal viewpoint, I believe the metrics of the vascular rehabilitation is considered to be simpler than those for the standard cardiac rehabilitation because walking is the primary focus, which is the lower extremity, and since that there is a real concern about the major side effects from during the rehabilitation. So it doesn't need the monitoring, but it is essential to increase the exercise intensity to the point of the moderate to pain or the discomfort. So many guidelines recommended rehabilitation therapy as a class 1, level A in PAD patient. Very similar with another situation of the cardiovascular disease situation. Fortunately, since 2018 September, also the Korean government insurance can cover all types of the peripheral arteries, such as intervention, bypass surgery, or even medical therapy. So you can use, if you have the willingness to use of such a peripheral rehabilitation. So we have some pain scales such as the oncologic or the chest pain or the sometimes the RPE. But during the claudication rehabilitation, we must know about the claudication pain scale. As I mentioned earlier, at least moderate to severe pain is needed to improve the claudication symptom or the walking distance, etc. So feel some severe pain during the walking exercise is very, very mandatory to success of the peripheral rehabilitation. So these are specific information about the exercise training program, about the frequency, modality, pain intensity, exercise intensity, duration, and how to maintain chronic exercise training after initial training for lifelong. So also we have another type of the exercise program such as using the arm ergometer or the cycle ergometer. Also, the previous presenter also mentioned earlier, I believe that not only aerobic training but also resistance training are also very, very important in peripheral artery rehabilitation. These are 5 easiest exercise for PAD patient, such as the intermittent walking, tall walking, calf raising, and step up, and calf leg raise. So if you don't have any knowledge about the peripheral rehabilitation, just recommend such kind of the exercise to your PAD patient. So it is not possible. So exercise snacking also good. Exercise is needed a very short duration and without any the equipment or the facility, etc. So just like snacking, eating, so we must recommend exercise snacking. Also, this is not possible. Also, weekend warrior is also good alternative to all cardiovascular peripheral artery patients. So any type of the exercise, any type of physical activity must be helpful for our cardiovascular patients. So some investigators suggest that they need some preventive medicine to prevention of the PAD and management of the PAD. So very early phase of the asymptomatic situation, exercise must be considered as the very fundamental treatment strategy from the very beginning of the PAD patient. So in a community level, so this is the very schematic and strategic approach must be needed. So this is one of my final slide. So given the robust evidence and strong recommendation now in place, it is expected that supervised exercise therapy will play the very crucial role in treatment of PAD patient. Its implementation is now considered very necessary at both individual and community level. So if appropriate exercise therapy is implemented through the supervised home or the hospital program, it is expected to reduce the symptom relief, improve the quality of life, increase working distance, reduce the risk factor, and enhance the function. These benefits are said to be the result of the underlying changes such as the improved mitochondrial function, increase the neovascularization, better endothelial function, increase the muscle cell, and reduce the inflammation level. So, ladies and gentlemen, this is my final slide. Please do PAD rehabilitation for your patient. Better than nothing after optimal rehabilitation strategy and medical therapy, even in asymptomatic situation. I would not recommend the following order. First, if possible, supervised exercise in hospital. But it is not possible, supervised exercise out of a hospital using the MS or the wearable device. And also, another alternative to community-based, home-based intensive exercise is also exercise snacking, weekend warrior, and all is not available. Just enhancing the daily physical activity is also helpful to our PAD patient. Thank you for your kind attention.